Hi, my name's Harriet. I was a med student at Birmingham and I'm now an F1 coming to the end of my first year working at City Sandwell. Today I'll be talking to you about a topic from your ophthalmology syllabus, glaucoma. So if we start by looking at the learning outcomes, by the end of the session we hope you'll be able to recall the relevant anatomy and physiology of the eye, which will hopefully enable you to develop an understanding of the etiology of glaucoma. You should be able to describe how glaucoma presents in patients and understand the principles of management of glaucoma. So let's start by recapping the anatomy of the eye. So we can see a diagram of the eye here with all of the relevant parts named. The eye contains a substance called aqueous humour. This is found in the anterior and posterior chamber here. Now it's important to differentiate this from the vitreous humour, which is more of a gelatinous thick substance and is found more posteriorly between the lens and the retina. The pressure within the eye is known as the intraocular pressure. From now on, this will be substituted to IOP. The normal intraocular pressure is between 10 and 21 millimetres of mercury. It is through the hemostatic regulation of the aqueous humour that we maintain our intraocular pressure. This diagram explains this a bit more. So we have active secretion of aqueous humour from our ciliary bodies, which is where it's produced in the ciliary epithelium. This then moves from the posterior chamber through the pupil into the anterior chamber. There are two routes of drainage. The majority drains through this trabecular meshwork here into the canal of Schlemm at the anterior chamber angle. This accounts for around 85 to 90% of drainage, and this path actually has some resistance to it. We've then got the remaining 10 to 15%, which drains at the iridocorneal or uveoscleral angle into the systemic circulation through the ciliary bodies. So how does this relate to glaucoma? Glaucoma is a syndrome which is characterised by raised intraocular pressure. This leads to something known as optic disc cupping, which we'll come to talk about in a bit, and can cause impaired optic nerve function. This will eventually result in visual field loss, and for this reason glaucoma is the leading cause of blindness worldwide. There are a few different types. The ones we're going to focus on today are primary open-angle glaucoma, which accounts for 70% of all cases, and then primary acute angle closure glaucoma. There's also secondary, resulting from inflammatory or traumatic processes, and congenital. So we'll start by looking at primary open-angle glaucoma. As previously mentioned, glaucoma is characterised by raised intraocular pressure. We know that the intraocular pressure is maintained through hemostasis of the aqueous humour. Therefore, we can say that primary open-angle glaucoma is caused by either the reduced drainage or increased production of the humour. It's important to say that obviously the angle is open. This is compared to acute angle closure glaucoma, which we'll go on to talk about a bit more later. The raised intraocular pressure results in retinal ganglion cell death. Now, the exact mechanism of this is not completely understood, but it's thought that it's possibly due to increased pressure gradients, compression of axons, and ischemia of the ganglion cells. There are a number of strongly associated risk factors, age being one, so age greater than 50. It's rarely seen in younger age groups. Family history, and this is inherited in an autosomal dominant pattern. If a patient is found to have an intraocular pressure of greater than 23 millimetres of mercury, it's thought that they are at high risk of developing open-angle glaucoma. And then also black ethnicity. Some weak risk factors include high myopia, and this is associated with the shape of the eye, diabetes mellitus and hypertension, so some systemic diseases there. In terms of presentation, it's usually asymptomatic and it's always painless. Patients will tend to develop symptoms a lot later on in the disease, and this will be a characteristic visual field loss. So normally they lose peripheral vision. Patients will tend to have normal acuity until late on in the disease when their central vision starts to become affected as well. For this reason, the NHS recommend routine eye tests, so every 2 years for adults, and it might be that if a patient has more risk factors that they're invited for eye tests more frequently than this. Due to the asymptomatic presentation, it's really important that we detect any cases of primary open-angle glaucoma early so that we can treat them preventatively. And some complications include retinal vein occlusion and blindness. So diagnosis is usually through multiple investigations. There's not one single diagnostic tool. As I previously mentioned, acuity will usually be normal early on, and it will only be in the advanced disease that this might reduce. We can use a Goldman applanation tonometer, and this measures the pressure within the eye, and obviously it will show increased intraocular pressure. Gonioscopy is something else we can use to look at the flow of the aqueous humour through the eye, and this will show an open drainage angle, as I mentioned previously. Ophthalmoscopy will show a number of features, namely a pathologically cupped optic disc is what you'll hear talked about when people talk about glaucoma. So if we look at these images, these both show the left eye. The top one is a normal eye and the bottom is a glaucomatous eye. So some of the features that we typically see on ophthalmoscopy, we firstly look at cup to disc ratio. Normal cup to disc ratio is 0.3, so if we look here, we can see this is the cup here and this is the disc, and the ratio there is 0.3. If we then look at this bottom one, you can see the cup is much larger when compared to the disc. A ratio greater than 0.5 is said to count as glaucoma. However, it's important to note that there are anatomical variants. Some patients may have a higher cup to disc ratio, so it's important that we compare the cup to disc ratios that we see over a period of time and also between both eyes. You'll also see optic disc pallor, as you can see here in the bottom image. The optic disc is much paler than in the top, and we'll also see pink rimming of the optic disc, so you can see this at the bottom here. There'll be a nasal shift of vessels, so as I said, this image is of the left eye. In the top you can see the vessels nicely here. If you look at the bottom, then vessels have shifted to the right hand side of the image, implying that they've shifted more towards the nose. Notching of the optic nerve cup is said to be pathognomonic of the condition, so we can see this here in the bottom image. And then hemorrhages are a more rare thing which we see on ophthalmoscopy. And then you can also look at visual field loss. So there is a characteristic glaucomatous visual field loss we see, which you can see in this image here. Initially you get a nasal step, and then this eventually develops into something called a scotoma. So, how do we manage open angle glaucoma? As I mentioned before, this is more preventative. We want to identify it early, treat the patient to try and reduce the intraocular pressure, therefore prevent any visual field loss. So first line treatment is medical. We give topical treatment in the form of eye drops. So if we go through each of these in turn, so firstly you've got prostaglandin analogues, for example latanoprost. These increase the drainage at the uveus scleral angle. Some side effects of this include transient redness at the time of putting the drops in. The iris may change colour and become brown, or you might get hypertrichosis, so increased lash length. Beta blockers, for example timolol, act to block the beta receptors in the ciliary body and therefore reduce the production of the aqueous humour. These become less effective with time, and they might be contraindicated in certain conditions due to the risk of systemic absorption. So, for example, asthma or COPD exacerbations, or bradycardia or hypotension. You've then got alpha-2 agonists, for example brimonidine, and these have a dual mechanism, so they increase the drainage and reduce the production. Allergic reactions with these can be more common. You've then got carbonic anhydrase inhibitors, for example dorzolamide, and these reduce the production in the ciliary bodies. And then cholinergic antagonists, for example pilocarpine, and this increases the drainage. So first line, you'll start with an eye drop either in first or second row. If these don't effectively reduce the intraocular pressure, then you can either switch to another drug in the same class, so another prostaglandin analog or another beta blocker. You can use these two combined, or you can add in or switch to one of the medications in the 3, 4 or 5 rows. So These patients will require eye drops lifelong and they'll be continually monitored. Follow-up will tend to be every 3 to 12 months, dependent on the severity of the patient's glaucoma. If the eye drops fail or they're contraindicated, so this might be in a cardiovascular or pulmonary disease, then we'll either use laser trabeculoplasty or a surgical intervention such as trabeculotomy or an aqueous shunt, and these are essentially acting to increase the drainage at the trabecular meshwork, which is where the resistance usually is. So prognosis, this is usually dependent on the degree of the disease at diagnosis, adherence to treatment and life expectancy. Obviously, if a patient has a longer life expectancy, they'll be living longer with glaucoma, be having to take these eye drops for longer, and it's more likely that they will develop some form of visual field loss. If glaucoma is left untreated with an intraocular pressure of greater than 30, then it's thought that blindness will develop in 3 years or less. So if we move on to briefly look at acute angle closure glaucoma. This is a medical emergency. As the name suggests, it's an acute condition. The drainage angle becomes acutely closed, and this causes a sudden rise in intraocular pressure to greater than 30 millimeters of mercury, resulting in axonal death. This may be primary, for example, anatomical or genetic predispositions such as hypermetropia, or it could be due to a pathological process such as a hemorrhage or a cataract. So if we look at this diagram again, in acute angle closure glaucoma, it is this area here which is first affected. This becomes blocked suddenly. This will prevent the passage of the aqueous humour from the posterior to the anterior chambers. This will in turn cause increased pressure in the posterior chamber, which will force the iris forwards, as demonstrated by this arrow. This will therefore cause closure of the anterior chamber drainage angle, hence the name. In hypermetropia, where the eye is smaller, this area here, where the aqueous humour passes from the posterior to anterior chamber, will naturally be smaller and therefore more likely to spontaneously block. Similarly, if you have a traumatic hemorrhage within the eye, this can cause this area to also be blocked off. So how do they present? Onset is usually hours to days, and the patient will have a painful red eye. They'll describe preceding halos around the lights and blurring of their vision, and they'll become systemically unwell, so they'll have nausea, vomiting, abdominal pain and headaches. On examination, if I show you this picture, they will have red eye, corneal haze, and you'll also see a mid-dilated pupil. So how do we manage them? As this is an emergency, the patient will need to be admitted to hospital. It's important that you avoid pupil dilation, so you mustn't put them in a dark room, don't put an eye patch on them. And for this reason we give a cholinergic antagonist, such as pilocarpine, which acts to constrict the pupil. We give a combination of topical and systemic medications in order to try and reduce the intraocular pressure at first. So beta blockers can be given, IV acetazolamide. This is a carbonic anhydrase inhibitor, so acts in the same way that was previously discussed in topical medications in open angle glaucoma. They'll also require analgesia and antiemetics due to the systemic symptoms. The definitive treatment for this is a laser iridotomy once you've controlled the intraocular pressure. Essentially, you're going to have to reopen the drainage angle which has been closed. So, just to recap on the learning outcomes, hopefully now you're able to recall the relevant anatomy and physiology of the eye. You've developed an understanding of the etiology of glaucoma. You are able to describe how glaucoma presents in patients, and you can understand the principles of management of glaucoma. So, thanks for watching. My email address is on the first slide, so if you've got any questions or anything, please drop me an email.